Good evening and welcome everybody. My name's Gary Howsam. I'm a GP in Cambridgeshire and I'm the Vice Chair of External Affairs at the Royal College of GPs. And I'm really pleased to welcome you all tonight to a joint RCGP NHSE event talking about the Community Pharmacy Consultation Scheme at a time when we know primary care is busier than it's ever been, and a time when we know the multidisciplinary team are all contributing to looking after our patients to make sure that people get seen by the right healthcare professional at the right time in the right place. This seems a really timely opportunity to talk about a new scheme which will help make sure we achieve those aims of getting people early and appropriate help at the most convenient point in time. We've got upwards of 200 people joining us this evening, a mix of GP colleagues and pharmacy colleagues and members of their wider teams, and welcome to all of you. I can see there's about 200 of you out there. I can't actually see any of you, but I think you can see myself and the panel who are here. I won't introduce the panel all at the same time now. I'll ask them to introduce themselves more fully as we move through the presentations, and there'll be an opportunity for some questions and answers at the end. If you do have any questions as we go through, if you click to the bottom of your Zoom screen, you'll see under the three buttons that there's a Q&A function. If you click on the Q&A function, then you'll be able to type a question in there, and we'll either address it during the course of the presentations or in the Q&A session at the end of the evening. So that's probably enough from me. Welcome again. And if I can just hand over to Ed Waller, who's the Director of Primary Care at NHSE. Ed.
Thanks, Gary. And I won't say a lot, but I just wanted to say thank you all for joining and having enough interest in this to join us in an evening. We know how busy it is at the moment in primary care, and we want to do everything we can to make sure that that is manageable for people working in primary care, but also that we can still provide a good service to patients and they can get everything they need from the NHS. And in particular, one of the things we're really concerned to do, as Gary was describing, is to get patients to the right place, be the right person at the right time. So the service you're going to hear about tonight does a lot of those things. It helps relieve the pressure, we hope, on general practice, and it's been shown to reduce the pressure in other parts of the NHS. We hope it also helps deliver a more clinical future for pharmacy, delivering more clinical services, part of what we buy from community pharmacy as the NHS. And so hopefully it's a win-win for everybody involved. It also means that patients can get timely care in a way that's convenient for them in many cases. So just to give you a bit of history, the Community Pharmacy Consultation Service was launched actually quite a long time ago in October 2019, initially making referrals from NHS 111. And over that time, we've seen nearly 350,000 people referred from NHS 111 calls at a rate of about 18,000 a month now from into community pharmacy, when those people would previously probably have been offered either a directly booked appointment through 111 into a GP practice or been referred back to their GP practice to seek help. So I hope that illustrates for you a little bit about how much potential there is here to relieve some of the pressure in general practice. In November, we extended the service by extending the contract with community pharmacy to allow referrals from general practice. Now, obviously, November was an interesting time for the NHS, a difficult moment in the middle of the second wave. And so we're taking this opportunity to highlight the service again, because there is much more potential in CPCS in GP referrals even than there is in NHS 111 referrals. So what is it? It allows low acuity minor illness to be identified at source in the practice and for a referral to be made for a same-day consultation with a community pharmacist. So the patient gets to see someone quickly. They get to see someone in a place that is often very convenient for them at a time that works for them. There is a route back of escalation to the general practice team if that's necessary. But what it does is leave patients getting the right solution for them, but also frees up GP time, so GPs can concentrate on the patients with the highest acuity needs where their training's best placed. So we know that the public have appreciated and responded positively to the consultations that they've had in community pharmacy. 86% of patients who chose to have a consultation with a pharmacist accepted the offer of a consultation with a pharmacist when it was offered. 9 out of 10 people referred to community pharmacy get a successful treatment episode or advise, and there's no onward referral. That also shows that in some cases there's a clear and effective path to refer into another service where that's the right answer for the patient. We also know that 9 in 10 members of the public say they trust community pharmacists, and 83% of the general public would be comfortable with being referred from a practice to a community pharmacy appointment. And the public recognise that that would allow GPs to spend more time with people with more serious needs. I hope that tonight in particular allows you to hear from some of the areas who really got going with this in some of our pilots. I think you're hearing from Richard later, but when I heard what was going on in Avon, when you hear both the GPs and the community pharmacists talk about how they've made this work, how they've built relationships around it that hopefully have a dividend elsewhere as people will start to develop their primary care networks, I hope you are inspired to go and do the same wherever you're working. So thank you very much.
Brilliant. Thank you very much for that introduction, Ed. So as we've just heard, we'll be talking to some people that are actually operating this service already, and to hear about some of the challenges of getting it up and running and some of the learnings from that. But if we could just start with our first presentation from Anne Joshua. Now, Anne's the Head of Pharmacy Integration at NHSEI. So over to you, please, Anne.
Thank you, Gary. So yes, I'm Anne Joshua, Head of Pharmacy Integration at NHS England Improvement. I'm also a pharmacist who's worked for a number of years in various clinical settings, but really excited to be talking to you today about this service on the Community Pharmacist Consultation Service. It's good. Can I have the next slide, please? So this is just an overview of the service as it is. Just to sort of set the scene, the patient will contact the practice for a minor illness, for a GP appointment, but in fact what they can be offered through this pathway is a same-day consultation with a pharmacist in their locality. And with the right consent, the information about that patient can be electronically referred from the practice to the community pharmacy, so that pharmacist has the ability to see what that reason is for that referral, and actually be able to start immediately to sort of understand the background that they need to look at for that patient. They all have an IT system that they use across the country. With all the pharmacies, they use nice clinical knowledge summaries, which is there deliberately to flag any red flags to the pharmacist when they carry out the assessment. And then at the end of the assessment, they will actually send a message back into the practice to let the practice know the outcome of that particular consultation when it's completed. So it's very much deliberately an end-to-end service, so that that whole patient journey is captured, and that's part of that whole sort of assessment process for the practice to be aware of. And as Ed said earlier on, the service was actually initially launched back in October 2019 as a 111 referral pathway. And in fact, from 111, in addition to minor illness, which we're talking about today, 111 also refers, in fact, people for urgent medicine supplies. So in fact, we're at the sort of 500,000 mark with the urgent medicine supplies. So pharmacists are used to having referrals and dealing with patients directly in this way. The service in particular, it was piloted in 5 areas around the country. And at that time, the work that was carried out there, it found that 88% of the referrals were completed by that pharmacist, and there was no further need for that person to be referred on anywhere else. There are very real reasons, though, and you'll hear a bit later from some of our colleagues about this, that there can be very real reasons when the pharmacist carries out that clinical consultation why it might be necessary to book that person in for a consultation a bit later, either a few days later, or it might be that same day, but depending on exactly how that patient presents. But that's accepted. That's sort of what would happen naturally. Certainly in the Southwest, and you'll hear from Richard later, they've been looking at certain times of the day and certain days of the week, you could almost achieve up to 10% of the practice appointments could actually be referred down to the community pharmacy in this way. We've had some really good feedback. And again, as Ed has said, we've had good feedback that practices are saying they would recommend this. What they found is it's enabling them to manage their sort of appointment workload for that day. So whether they actually, when they first say on a Monday, get the appointments in, it's a good way of actually looking at their appointment slots and saying, actually, these people, we could safely send them to the pharmacy. And if, that is for that same day appointment for that patient, the best journey, that is, again, something that the patients have really appreciated. Over 10,000 community pharmacists are actually registered to deliver this service. And we know that the referral pathway from general practice, we need to grow over time. And there are many practices now looking at this as a way forward. And again, you'll hear from colleagues later about the fact that there is some training available for community pharmacists, up to 16,000, jointly delivered by the Royal Pharmaceutical Society and the Royal College of GPs, to cover clinical assessment skills in the context of this service. So could you have the next slide, please? So, and if we could pass on to the picture that's in the slide, you might have to press the return. I hadn't realised that was going to happen. So the GP referral pathway, there are that sort of top blue line really is trying to show you that the patient can contact the practice, and the practice may triage that patient either using a clinical tool, or it might be non-clinical streaming, as we call it. And then the GP practice will send the referral on to the pharmacy, and the patient has that consultation. You'll hear from Hamad a bit later about the technical implications of all of that, but it's really just to sort of emphasize that the model is trying to show it is a pathway. It does work swiftly, it can work very safely, but there are many sort of ways in which you can enter that, whether it's literally through face-to-face, phone, or online. And Hamad can talk about that a bit later. So you can have the next slide, please. There are a whole range of conditions or symptoms that can be referred, and this is it's not the full list. It's not meant to be exhaustive, but these are the case mix that have been very safely referred now for over a year or more from 111, and this is the sort of the group of that is felt to be the most appropriate to refer to the pharmacy. And if we move on to the next slide, that will show exactly, if you like, what has been happening between 111 and general practice. We're seeing more or less the same case mix. So in 111, at the moment, and this is very recent data, we're seeing sore throats, hoarse voice, for example, is being the top of the list. In GP practices, it's skin rashes. But as you can see, it's more or less the same case mix that's coming through. And certainly in terms of the practices that are referring, we have 13,000 patients that have been referred since October to this month, and that's from 280 practices. We've already got 20% of all practices in England getting ready to prepare for this referral pathway, and we're really, really keen to actually really work with practices in their areas to make that happen. The implementation of this pathway is done through our regional teams and through our regional colleagues, and they've been working really, really hard, working across with ICSs and CCGs to work on some of the very practical ways in which this can be implemented. So we go to the next slide, please. In terms of the different sort of what can happen at the consultation, this is the sort of the key categories if we sort of look across the list. We've got, it could just be advice only, and these are very real consultations that people have experienced. So whether it is somebody having problems with sleeping, and this can just be general advice. It could be advice which would lead to sale of an over-the-counter medicine. So that, again, is sort of everyday sort of practice really for pharmacists, but it is a very detailed conversation in a consultation room if that is preferred, or it can be done remotely. And certainly since the COVID pandemic, we've had telephone consultations and video consultations by this route. But it can also be advised and then maybe referred on to another NHS service that's delivered within the pharmacy. So this, for example, is a scenario where it might be it's a child, or it could be another adult with a sticky eye, and there could be something that is very suitable over the counter, but in the context of it being available for a child, it could only be prescribed, but actually could be sold to an adult. So through an extended service, through a patient group direction, which is commissioned locally, there are some areas now who are thinking about providing this as an enhancement to the CPCS consultation. And then also there is advice, but there might be the need to signpost on to other services. And that's really that sort of knowing what's available in the area, as the pharmacists do, and then making the right signposting. And then finally, it could be the scenario, and they are real, but they're very rare. It might be necessary that somebody needs to be referred on to a higher acuity. It might be A&E, but it could be that that individual might need to be booked back in to general practice for a consultation. So we can move to the next slide, please. So some key things just to think about in the context of implementation. There are issues around governance, the referral process, the tools that can be used for triage or working out how to stream those people through and the patients through, the staff training and awareness, so that would be with care navigators, reception teams, the clinical staff in the practice. And do you need, for example, and we do have materials to help with this, scripts to help the reception teams to facilitate the right sort of referral? And what sort of communications need to be established within the practice and in terms of making sure we've got that end-to-end process? Within a primary care network, we found it's very helpful, and the experiences we've had within the pilots in the context of feedback and incidents, patient satisfaction and shared learning. And that's something I know some of the pharmacies are very keen to work with practices on, in how to do that feedback, and particularly in the early days of implementation. And then finally, patient-facing communication. So are there certain messages you might need on your practice, on the answer phone, on website, in the context of digital screens or any leaflets? All of these, we've got resources that we can help with. So we move to the next slide, please. So we've produced a toolkit, which is available to practices, and this is available on the Futures NHS website, which does give some of those sort of resources and details available to people, so that they can sort of access sort of top tips and Q&As, whatever's needed really. So we move to the next slide. And I think you'll find on there's a whole load of resources with the links through to the websites on the Future NHS website, where the toolkit will be hosted, and also case studies, as well as NHS England for our own website, with the materials listed there for you to look at and reference. And also there is a very useful animation that the PSNC has produced on its website, which is, we found certainly for practices to actually watch that animation has been extremely useful. So Gary, I think it's hand back to you.
Okay, and thank you very much, Anne, for that introduction to the service. And it, as you've highlighted, it's not really a new service. This is just the latest iteration of a service that's been in place and been running successfully. I can see that people are starting to put questions into the Q&A section. Thank you for that. We won't answer them at this stage because I think quite a few of them will probably be picked up in subsequent presentations, but we will have a look at those at the end. So if I can hand over now to Hamad Patel, please.
Hi all, my name is Hamad Patel. I'm the Pharmacy Integration Lead in the NHS England team that covers the London region. I'm also a prescribing advisor at North Central London CCG, and I'm a community pharmacist by background. Next slide, please. So this section, it covers the digital referral element of the pathway and is designed to kind of raise awareness and provide some clarifications. So just a reminder that part of this pathway involves patients consenting for their information to be sent across from the practice to the respective pharmacy, and it's a requirement that this information is sent by a secure electronic route. So verbal signposting is out of the scope of the NHS Community Pharmacy Consultation Service. You may have seen NHS Mail referred to as a minimum viable product. I guess it's somewhat of an unfriendly term to mean that this is a secure, easy to use and free of charge option. However, local solutions that may exist or be sought can be used to send the referral information across to the pharmacy if they meet the criteria for the referral service. So the referral information must consist of a minimum core set of information. That includes things like patient demographic information, contact details, and obviously the reason for referral. And the GP PCN toolkit, like I mentioned, is one of the resources that's on the Future NHS workspace, and it provides an example template of what can be included or what should be included in a referral. Apologies, there's animations on the presentation. If you skip to the next point, sorry. That's it. Another point about the Future NHS workspace is that it hosts a variety of different resources, not only covering digital referral elements, but also pre-recorded demos and support articles also. So next slide, please. So how does the pathway work? And just cover that in detail. Again, there's the same diagram, but just to kind of mention that the information in this section kind of covers that point 3, which is the actual transmission of that referral from the GP practice over to the pharmacy. So next slide, please. And next slide. Yep, that's it. So in terms of the current CPCS referral options, they can be categorized into 3 main routes. The entry point into all 3 routes is the same, and it's initiated after some kind of patient contact. Again, the higher level overview shows that that could be face-to-face, over the phone, via online consultations, etc. But however that patient enters this pathway, there are 3 main routes for kind of transmitting that and recording that referral in the practice and then across to the pharmacy. So the first one is NHS Mail. Again, I referred to that in my previous slide, but particularly NHS Mail used in conjunction with a clinical template. So a clinical template that sits within the GP clinical system. So once that patient contact has been initiated and it's been deemed appropriate for referral across to the Community Pharmacy Consultation Service, a practice staff member would load the clinical template, like all clinical templates are loaded, and complete the steps by inputting the patient information that's been provided to them. And if that patient contact has come by an online consultation route, then again, that information can be transferred across that template. It allows the information to be recorded in the patient's notes, and then the clinical template would also allow the sending of that document across the pharmacy via NHS Mail, which can be used the mail merge functions of different clinical systems, or can be sent as a separate email. So the advantage of the NHS Mail or NHS Mail with a clinical template is available to all practices and community pharmacies. It's widely used and easy to use, and it's practice staff are also well versed in using clinical templates. They're easily launched within the clinical IT system, and it again allows for that safe and effective recording of information in the patient's notes. The second option or second route is termed kind of standalone options and solutions. Practices may be familiar with some such as PharmRefer. Sonar has a CPCS referral system also, and there's a few others, and other applications have been kind of repurposed also for sending across CPCS referrals. These often rely on a dedicated web page or portal application that sits outside the clinical system, but the steps again are the same, where the referral information is completed and manually entered, and then a pharmacy email address or pharmacy is selected from a list. If there's a proprietary link up with that solution, and that referral can then be safely sent across. Depending on the option, there's a different varying levels of functionality and integration with the clinical system itself. And the last main route is options that are within the GP clinical system itself. we are only aware of one such system that's currently available, and that's the EMIS Patient Access Connect option. So currently only available to EMIS web practices, and that links up with the Pharm Outcomes CPCS IT system in the pharmacy. It sits within the clinical system, like I mentioned. A button is clicked and you follow the number of steps to follow that process across, where a pharmacy can then be selected and that information sent across to the pharmacy that lands directly into the Pharm Outcomes platform. Next slide, please. So all three of the referral options, that kind of referral routes, mentioned on the previous slide, have all been used successfully across the country during the pilots, and now since CPCS has been an NHS GP referral pathway to CPCS has been a commissioned service. There is no one right option, and the pathway has been designed to give that flexibility to practices to make the decision on the route that best suits them and their needs and the existing IT infrastructure that's available to them. Some areas have considered applying a more consistent approach in terms of the referral route across wider footprints, and that has been valuable in some areas in supporting stakeholders to engage in this pathway. We would always advise seeking advice from the digital primary care leads, and in particular the GP CPCS regional implementation teams in your area. And again, contact details are on the future NHS work page. Can I have the next slide, please? So I wanted to quickly cover a couple of myths that we've encountered. The first one being that practices must have or procure a new dedicated IT solution to send platforms, and the simple answer is absolutely not. So whilst local solutions can be sought, existing tools and NHS Mail, especially with a clinical template, can be used very effectively. Next point, please. And the next one. So referrals via NHS Mail, like I mentioned, have been used throughout the pilots and are still being used actively. And the next point shows that 77% of practices who have engaged have indicated that they will or intend to make referrals using NHS Mail in conjunction with a clinical template. Next slide, please. So the next myth we've encountered quite a lot is sending a formal referral will take just too much time. And the last thing we want to do is burden staff. But as it's been mentioned already, 95% of our practices in the evaluation stated that they found the referral process as quick and easy, or very easy, and it fits within their everyday processes. And they very much saw this as investing some time up front to save more time further down the line. A particular benefit of this pathway is a provision of that robust audit trail and the opportunity to close the loop with a post-event message, so maintaining visibility of that patient and their patient journey. And we're aware that practice reception staff have significant experience of signposting patients appropriately to community pharmacy, and that's been further enhanced by their day-to-day activity of determining which clinician or allied healthcare professional in the practice can best meet their patients' needs, especially with all of the additional roles that are coming into primary care. Next point, please. Ultimately, this comes back to the fact that good access is not just about being booked in to see someone, it's about seeing the right person at the right time in the right place. And lastly, I think the point that's already been made is that particularly PCN clinical pharmacists working in practices and PCNs are ideally placed to support practice staff with referring to CPCS, and also more widely about what community pharmacy can offer. Next slide, please. And the last myth for this day is that community pharmacists cannot document referrals via NHS Mail. Again, no, absolutely not. So the referral information received by NHS Mail can be manually entered into the pharmacy CPCS IT systems. Again, currently those are Pharm Outcomes and Sonar. Once they receive this information from the practice, even if the patient DNAs, again, that's in there to ensure there's safety netting, good governance, and also the post-event message kind of comes back as a consistent messaging, and you've got that visibility of your patient. And these are links to the particular pages that host these step-by-step guides for that process in the pharmacy. Next slide, please. Just looking towards some future developments. So as I mentioned, online consultations is a route into the service potentially, but currently all of the referral options do not automatically integrate with referral options and online consultation platforms. So the ability to refer directly from your online consultation platform is under development and will be piloted by the Digital First programme, and it's slated to undergo that pilot later in the summer this year. And next point, please. And another future development or ongoing development really is the better integration and the full integration of post-event messages back from the pharmacy into the GP clinical system. So again, in the same way that you currently receive urgent medicine supply notifications and flu vaccination notifications directly into your GP clinical system workflows. That's everything on this section. Thank you.
Okay, thanks very much, Hamad, for that introduction to some of the IT that is supporting this process, but also the flexibility that's built into the process to allow people to access the services in different ways. One of the questions we've been asked is whether we'll be sharing the links that are in the slides, and I confirm we'll be sharing the links and the slides as well as the recording of this afterwards. But if we can move on now, please, to Mo Uma, and Mo's going to give us his experience of actually using the service down in his practice. Thanks very much.
Thanks, Gary. So I'm Mohammed Uma. I'm a GP in Darwin in Lancashire and clinical director of Blackburn with Darwin Primary Care Networks and chair of our local primary care federation in Blackburn with Darwin. Next slide, please. So just to give a bit of context for colleagues who might be able to resonate with some of the demographics in our area. So just a bit of background. In Blackburn with Darwin, we've got around 183,000 registered patients. We have 4 PCNs, which effectively operate as one through our sort of federation as a vehicle of delivery. We have 23 general practices serving those patients. And we initially started this as a pilot, which is now a service in Darwin, which is one of our PCNs, which has around 35,000 patients served by 3 general practices and 6 community pharmacy providers. Next slide, please. So why bother as GPs or PCNs getting involved with this? And I think in common with many areas, we're facing similar challenges around increased demand. The complexity that GPs are dealing with has increased significantly over the last sort of 5 to 10 years. And we're all hearing around the workforce challenges and recruitment challenges for primary care. There was the Time for Care programme, which tried to release GP capacity, particularly around improving access, to try and work out what non-GPs could do, what other members of the workforce could do to try and help release time for GPs to focus on more complex problems. And care navigations was one of those areas. And we implemented that a few years ago, care navigation or active signposting as it's called. And what we found was community pharmacy was by far the place that most patients were being signposted to by our reception staff. And part of that program, we trained up around 130 of our reception staff across Blackburn with Darwin to safely refer into community pharmacy. So for us, it was a bit of a building block for this service. As part of our care navigation program, we designed a template around safely referring patients into other services and giving patients that choice, whether they not necessarily needed to see a GP. So we already had a template incorporated into our IT systems, and this really built on it and accelerated that. And my manager colleagues will talk about its effectiveness. We worked in part to, what else did we do to try and really make it successful? I think one of the key components is GPs working in partnership with local pharmacy committees and community pharmacies, really to give getting that sense of willing commitment and providing that support for everyone to work in partnership to provide something for our patients, which is of a high caliber, which is what we want to do ultimately as GPs if we are signposting patients and referring patients elsewhere. Really, again, another really key component is making sure we engage our patients, and through our patient participation groups, we engage with our patients to explain to them this is not about you not having access to your GP. These are highly trained professionals as well, providing care around problems that they're capable in managing with. So really important to take our patients with us. It's important to provide some development support for community pharmacy, and as Ed mentioned earlier, there's that RCGP training to support community pharmacies. Because the training, what we found in our experience was they've not got that historical training around taking history taking for conducting history taking, for example, and some of that support was needed to help them make sure we don't miss any red flags, for example, and also support around managing patients through patient group directives. And we designed some patient group directives locally for certain minor illnesses such as uncomplicated urinary tract infections in women, conjunctivitis in children over the age of 3 months, and acute tonsillitis. And that helps support the community pharmacies to prescribe under a legal mechanism within their own sort of responsibility and competence. The other important bit around support for the community pharmacists is also around having a direct phone line. So as we want to, ultimately we want the patients to have good experience of this service, making sure if there was any complexities that needed to be escalated back to the GPs, community pharmacists have that quick access for support from GP colleagues. And as I said, as I've emphasized, the real key is around engagement and support for local community pharmacists to feel mentored and supported, that they're not out there managing conditions that they haven't managed previously, that were historically managed by general practice, and they feel supported in delivering that to help us ultimately to free up time to manage more complex problems. Next slide, please. So what were the local outputs? So patients had an alternative access to a healthcare professional for a minor illness where a GP was not necessarily needed. It allowed us time to focus more on complex conditions. So over a sort of an 18-month period, we saved around 135 GP clinics across our 3 practices. It's helped develop better relationships with community pharmacists through that training and through the contacts that we've had with our local community pharmacists. And that helps with some of the simple stuff that we have to deal with in general practice. So, things like, there's manufacturing problems with medicines, just some of the interfaces that community pharmacy have with general practice. And that's just improved by having something to get around together with. The service has been valued by community pharmacists. I think they felt that they've been working at a higher level of their competence and training. So that makes the role much more rewarding as well. And from the numbers that I just explained over the 18 months, we started this in one of our PCNs in Darwin, and we're planning to roll that out across the town. And from a future point of view and a strategic point of view, we know community pharmacists will have to become signatories to the PCN DES. And this is one way of getting people together to focus on an item in an agenda for PCN meetings in the future, to help develop them relationships and help us work together more effectively. Next slide, please. So I'll pass over now to Anne and Fran, who are practice managers in a couple of the Darwin practices, and they can talk to you about a bit more detail around the operationalizing of this at a practice level.
Hi everyone, my name's Anne Neville. I'm a practice manager at Darwin Healthcare, and we have a patient list size of around 13,000 patients.
Hiya, I'm Frances Proctor, practice manager at Darwin HealthLink, and we have a list size of approximately 16,000 patients.
Next slide, please. So we're going to tell you a little bit about the Darwin PCN profile, how we implemented this service, how we raised the awareness, what our performance was, and what the key points are to take away. Next slide, please.
So just to let you know a little bit about who we are, I mean, we're Darwin Primary Care Network. It's one of the 4 Blackburn with Darwin neighbourhoods. We're located in a large rural area with a small population. The PCN comprises of 3 GP practices, 2 of which are located within Darwin Health Centre, with a total patient population of, like has already been said, 35,000. We have 6 community pharmacies in the area, and we already have established a really good patient involvement with our Healthy Darwin community group. Next slide, please.
So if we go back to around September 2019, Darwin was a pilot site for the CPCS. We'd already routinely care navigated for about 2 years, so our receptionists were really used to navigating to the local pharmacies for minor illnesses. We piloted 3 illnesses previously, which was uncomplicated UTI, sore throat, and conjunctivitis. And this was done by the community pharmacists being trained to prescribe antibiotics, as Dr. Uma has told you previously. I think what this did, it gave patients the confidence in being consulted with by our local pharmacists. And so this service was really an extension of what we were already doing. There really wasn't any additional work for our care navigators. In the very early days, back in August 19, the system was a little bit more clunky because we weren't able to refer directly through our EMIS clinical system, but we're now able to do that, so it's much better. So how does it work in our practice? So a patient contacts the practice by phone. Some of them now are so used to the service that they'll even email us about it. The reception care navigator will go through the usual care navigation process. They use the template, and if it's found that they are suitable, the illness is suitable to go to the pharmacist, then the care navigator will automatically refer electronically through the EMIS system. The patient can choose the community pharmacist of their choice. And once we check the details to make sure we've got the correct contact details, that we've got an email address, and the patient will then get an email back to confirm that that referral has been accepted. What we find locally is that our community pharmacists, they normally respond to that referral within about 4 hours. Once the patient has been seen, we will receive the documentation back, which actually comes into our generic email account. We actually attach it to the patient record, we code it, and we file it. It was really important in the early days that we had an escalation process, so that if a care navigator referred a patient to the pharmacist and it really wasn't appropriate, that there was a quick process back to the GP practice, so that there was no delay in the treatment. And so we all provided the community pharmacists with a emergency number that they could automatically contact, and they will go through to our lead GP and they will get the treatment sorted. So if they have to come back to the practice to be seen, that's fine. It may be that the lead GP can actually prescribe by taking the information off the pharmacist. The patient does have the choice to say they don't want to go to the pharmacist, and if that's the case, the doctor or the healthcare professional who sees them does encourage them by educating them to use that service in the future. And what we do find is that once patients have used it once, they will use it again because they've got confidence in the system. Next slide, please. So in implementing the system, the 3 practice managers and our clinical directors, we worked together to implement it. We felt it was really important that our reception staff received face-to-face training, so they actually understood the difference to what they were already doing. As you've already heard, Dr. Uma provided training to the 6 community pharmacists on prescribing antibiotics using the PGD. Because our reception staff and care navigators were already used to care navigating, the CPCS was just really an extension of their current process. The reception staff all had laminated sheets on the workstations so that they could automatically refer to the scheme if they weren't quite sure whether they could refer for a particular illness. I think it's brilliant that the system now works directly with EMIS. You know, you've got your patient up on screen. You can just simply click the referral button, your template drops up, and the receptionist just simply types in the details. We actively publicised it in our waiting rooms, local pharmacies, the practice. We put it on our PCN newsletters, we put it on our website, and we really got our patient participation groups involved in the process. Next slide, please.
So how did we get the message out? What did we actually do? So Anne's alluded a little bit to how we got the message using social media. We put it on our in-house TV monitors. We utilised the NHS advertising campaign. We also put it on the websites, and we managed to successfully promote the service. The campaign was really useful, as not only did it get the word out, it reinforced a lot of the work that we were already undertaking in practice with care navigation. To promote the service further, we found that raising an awareness of the community pharmacist skill set was invaluable, as most patients were not aware of what a pharmacist can do. In order to do this, we used the pharmacist NHS videos in-house and online, and we found that all these tools were really well received. Next slide, please.
So this just gives you a little idea of the referrals that we have been able to do, and this is only up to March 21. So just 3 practices, and you can see where we start in September 19, we go up to a peak in January 20, and then we start to have the COVID issues, and you can see there's a dip, but we're now sort of working our way back up, and referrals again are routinely going through to the community pharmacies. So just on our 3 small practices, we've effectively saved around 135 clinics. I think it's been a really good service, and I do have to say that we had a fantastic gentleman called Bruce who actually really supported us through this whole process. So thank you, Bruce. Next slide, please.
So what did we learn along the way? We found that the patients were happy to accept the referral service when it was explained. The quick access to treatment, the advice for minor illness was really well received by both the patients and the practice. The receptionists are key to the success, as they are referring our patients with the correct information and not just signposting them. Our relationship with our clinical pharmacists, as already alluded to, is fantastic, and we have a direct line for pharmacists to the practice, which is essential for urgent contact with the lead GPs, ensuring a safety mechanism is in place. Appointments that have been saved can be utilised for patients that require the input of GPs or practice clinicians' input. We have found that it takes everybody to come together. All the stakeholders are very important in making this success. The receptionists, the GPs, the pharmacists, and most importantly, our patients. Thank you.
Thank you.
Okay, that's great. So thank you to Mo, to Anne and to Francis for talking us through how they've actually got this off the ground and running across your location and with your practices. I think that last slide there really covered all of the important features that I'd been writing down as we went through. I think we've identified a real need for this service, and there's an obvious solution out there. We've heard a little bit about the IT support for it to make it run smoothly, but as ever with these things, it's about people coming together and collaborating and just giving the project that first bit of momentum to get it moving. And it sounds as if it's been successful for you, it's been successful for your patients, it's been successful for the community pharmacists. And it's the indirect benefits as well of building up trust between different teams working across different elements of primary care. So fantastic story to hear about. We're going to move on now to Richard Brown, and he's going to be talking a little bit more about experience from the Avon LPC point of view. Thank you.
Thanks, Gary, and good evening, everybody. So, yeah, my name's Richard Brown. I'm the Chief Officer of Avon Local Pharmacy Committee. So it's great to be able to come and talk to you tonight about the project that we've been running since we went live with the pilot about 18 months ago. Next slide. Okay, perfect. So to give you a bit of an overview of where we're at, we cover areas around Bristol, North Somerset, South Gloucestershire and Bath. And we started as part of the pilot of delivering this project back in August 2019. Where we've got to currently, and I have a fantastic implementation manager in Judith Poulton, who some of you may have seen on some of the previous NHSE webinars. She has been working tirelessly to get all of our surgeries live. And as you can see, over the next few weeks, we're likely to be at about 80% in terms of rollout to our surgeries, which has been absolutely fantastic. And what's really interesting is, as you can see, we're nearly at about 12,000 referrals. So we've got a lot of experience now across Avon as to making this work across an entire system, which I'll talk you through now. So next slide. So if we have a look at our data, so similar sort of thing to what you just saw in Darwin, you know, we were progressing quite nicely up until sort of February, March of last year. And then as we were all hit with COVID, and what was really interesting was that we were able to demonstrate that we had changed the behaviours in our surgeries, because very rapidly we bounced back to a similar number. And then as you can see, we just plateaued. People just didn't have the headspace to start to take on something new. What's been really interesting though is as we have then gone through kind of March and April, as a bit more headspace has occurred in general practice, you can see that our numbers have rocketed up. And you know, we're hitting sort of 1,600, and May is looking like it's going to be something similar in our data set. You know, my challenge to my team is, when do we start to hit 2,000? You know, and that's 1,600 appointments that we've now freed up in a singular month from general practice, and supported our community pharmacists and allowed those appointments to be seen by potentially more complex patients. So it really is starting to gain traction across our LPC now. Next slide. So in terms of a couple of things that have already been discussed today, so it's really interesting. We've heard lots about those referral mechanisms, and there is a variety of referral mechanisms. And looking at some of the Q&A that's been popping up, you know, what is the best system? Well, you know what, it's about what is the best team approach. As with anything in life, it'll come down to what worked best in your surgery. And I have to be honest with you, about 2/3 of our referrals have occurred via NHS Mail using either EMIS, which is our dominant system across one CCG, and also System 1 using the Ardens template in another. It's a great way of working, and absolutely, at a surgery level, you should use the system that you are most comfortable with. Often we spend time looking for complicated ways of automating processes, when actually sometimes the simplest things work the best. It's nice and quick and simple, and there's been a video produced in terms of using the template that takes, you know, reception colleagues well under 2 minutes. And as you can appreciate with these things, as people get more used to using it, the quicker they get. There are some surgeries that do want a fully integrated solution, and therefore that choice is still important for the surgery, but they do both work. And it's down to the determinant of success is actually the way that the reception team and the whole surgery build really strong working relationships with the community pharmacy. It's absolutely correct what the Darwin team talked about. That relationship is the key to the service. Next slide. So in terms of things to think about when going live, it's about the conversations initially with the practice manager, or potentially somebody who's the lead in the surgery. You know, as we said there, GPs rarely get involved in our rollout in Avon. Obviously, they absolutely need to know what's going on, and you know, GPs in different surgeries will approach it in different ways, and we get different sorts of questions from GPs. But often, once they're comfortable with the process, actually, it's down to the team that really lead the reception staff. Nice and simple process in terms of going live, and the support and the training that we support in Avon, but I appreciate across the country, different systems have got an implementation rollout in different ways. And we, you know, each surgery in the country should understand and work with NHSE to work out what that is. Obviously, as you can appreciate, we've worked with EMIS, we've worked with System 1, and you know, that referral mechanism is key for you to figure out as to exactly what's going to work for you in your surgery. Next slide. We've touched on people discussing the conditions laminate sheet. Absolutely important to have that on the desk with the receptions team. It's really important to understand what that escalation route is. We've already heard in previous presentations, you know, what does the pharmacy need to do if they do find somebody that does need to be seen that day? It's really important, and we use the professional line into the surgery. We phone it through. We do not rely on things like email because they get missed. Really important to handhold those patients back carefully to make sure that they're properly cared for. Equally, we need to understand how the pharmacy is going to initiate it. most of our surgeries are now live with the process that the pharmacy will make first contact with the patient. And that seems to have worked really well. And we introduced that for the pharmacists to be able to phone the patients during COVID. And we've actually stuck with it because it has actually enabled the pharmacist to then pick up a conversation with the patient at more of a time convenient to them. And like people have said previously, that happens within sort of 3 or 4 hours, which is probably quicker than that patient would have actually had an appointment had they been booked in. Receptionist team leaders are important, and it's important around how we look at training the surgeries. And we've, like I said, led on that. And if we move on to the next slide, I'll show you the impact of the training that we deliver. So you can see there's a number of lines there running from September through to January, and this was September 2019 to January 2020. This is surgeries that had said they were now live. As you can see from the lines on the graph, they weren't really. They weren't actually engaging with sending anybody. We then started a program of face-to-face training in the surgeries. And as you can see, our first practice with training week commenced on the 6th of January, and they leapt up to delivering 20 referrals in a week. Now, obviously, with any of these things, things do plateau, but it shows the importance of engaging the surgery team and the surgery reception team with why this process is important and how to go about delivering it. It's not something that you can just land by an email and expect it to roll out by a bit of osmosis. It just doesn't work. We have to support our surgery teams in the rollout. Next slide. So in terms of what happens in the pharmacy, well, you'll be pleased to know, obviously, pharmacists are absolutely checking for those red flags. And we know that our pharmacists are checking that. And we are also seeing that there are some things that do get picked up by the pharmacy team. And that's what's really good around this, is that that does mean that we're picking them up and we're then escalating those back to the surgery. Next slide. Also, what's get picked up is things around what happens to the patient in the pharmacy. Well, lots of patients, you see that 35% of the patients are dealt with appropriate advice alone, i.e. no product has to be purchased, nothing has to be done. Actually, advice and potentially things they already have at home are perfectly okay. And when people ask questions around, does this work in deprived areas? Absolutely it does. And in some of our most deprived areas that we have in Bristol, the service works really, really well because patients understand how it works and how to gain access to that treatment quickly, which is what they actually need. So it is genuinely a misconception that these services don't work in deprived areas. They absolutely do. And again, about a third of the situations, it's advice with the sale of a product. As it says there, 11% of patients are escalated back to the surgery. And when I talk to people about this, some people feel that that's quite a high number. But as I point out, that means that 9 out of 10 people that would have had an appointment in your surgery either that day or the coming days do not have it. The pharmacist finds the one person out of 10 that you really did need to see that day, and manages to have a conversation with you to give some information about that clinical presentation and to understand why they need to be seen. And also we encourage our pharmacists to give an understanding as to how quickly they need to be seen, because that's also really important as well. And equally, we do have a suite of PGDs that have been commissioned by our CCG to augment the service. So we do also pick up things like minor urinary tract infections in females and a number of other PGDs. And that's just work to I suppose, furnish us with more presenting complaints that we can actually manage in the pharmacy. Next slide. So a couple of myths then. We've already touched on the one about what happens, whether people will go for the service or not, depending on whether they buy, whether it needs a purchase. Well, as I've shown you, not everything needs a purchase. Advice is perfectly acceptable. Doesn't matter whether it's a deprived area, it does work everywhere. And what's really important, that community pharmacists have already been dealing with these sorts of patients on a regular basis. So this isn't necessarily something new, it's a new pathway into the pharmacy, but the sorts of patients that we see through this service are, to be fair, the sorts of patients that I used to manage on a regular basis when I was practicing. Certainly when I used to practice over the weekend as well, when less of the system was open. These are not uncommon things for a pharmacist to see. They're just patients that have accessed the health system currently through the surgery. And that for me is what we have to get better at with this project. And that's why I believe it's a huge success, is that we need to see the right patients in the right place at the right time. And this service starts to allow us to be able to do that. And we just need to escalate just the 10% of patients that need to be seen in general practice that day. Next slide. So lastly, just to finish off, this is about helping these patients with their minor illness today. The pharmacist will see them today and will be able to assess them clinically. That's absolutely what we do in pharmacy. We're also starting to educate these patients around visiting the pharmacist first. Now, people say, well, what does that mean for the longevity of the service? Well, I can assure you, I've got some pharmacists that have been doing this for some time now, and they have not seen a drop-off. They will still be seeing, happily, 5 to 10 patients every single day, and that's supporting their local surgery with a reduction, a redistribution is probably a better way of saying it, those 5 to 10 appointments every single day. There are other things that we might be able to do in the future with other pilots that might come online in terms of other referral mechanisms but certainly at the minute, this is a great way of supporting general practice. It does also enable you in the surgery to increase your capacity, and you should see the community pharmacist as an extension of your surgery. And actually, for the first time ever, this really does start to form those clinical pathways between two key parts of primary care working together. And as we've already heard again from the Darwin example, some of those relationships that get built within delivering this service actually deliver far more than just this service. It always amazes me how close an opportunity we have to work between general practice and community pharmacy. And I think this service absolutely delivers on that. So certainly we've had a huge amount of success delivering this in Avon, but we still need to grow further. I have some very lofty goals for my team to achieve, and they're well on the way to doing that. And I hope and encourage you all to start to engage in that journey as well. Thank you.
Thank you, Richard, for that presentation. And I mean, as you've just alluded to there, this really is just a starting block for moving on to a whole host of other potential opportunities for us to work closer together across general practice and community pharmacy. And I think if you are told most GPs that there was a mechanism whereby you could filter out 90% of the cases that they didn't need to see, they'd jump at it. And I think the other really important thing you touched on there was managing patient expectations. And I think if they use the service once, they're obviously keen to use it again, but it also opens up and just strengthens the case for self-care and empowering people to look after their own health, which is something that, again, is a common aim of all of us. I'd like to hand over now to Johnny, who is going to talk to us about the training elements. Thanks very much.
Thanks very much, Gary. So I've got the final slot for you, and I'm delighted to be here. I'm a GP in the New Forest, and I'm also a medical educator, spent my life teaching communication and consultation skills. Back in September, October of last year, the LCGP with the RPS devised a really fantastic program for teaching pharmacists consultation skills. And I'm going to take you through a canter of what we do. So there are 2 sessions that are run. They're both 2.5 hours each. They're run throughout the week on different days and at different times so that they can be convenient for the community pharmacist to attend. And they're sequential weeks. So same session, 2 sequential weeks. So we use a web-based platform called Ventry. I hadn't come across it, but it's perfectly satisfactory and doesn't involve any uploaded apps. Session 1 starts with clinical history taking and consultation skills, moves through to red flags and observations, clinical assessments, and then putting knowledge into practice, and how can pharmacists and general practices work together for the benefit of our patients. So let's canter through this. We use a Calgary-Cambridge observation guide. Any GP or GP trainee on the webinar will recognize this as a very standard consultation style. It provides structure to a consultation with the patient, and it also builds relationships as you go through. The introduction is via a mnemonic that was devised up in Manchester. It's relevant to pharmacists, uses I2C6 as the mnemonic, and it basically just takes you through an introduction with a patient. The information gathering is another mnemonic, and anyone that's been to medical school will have come across this surgical sieve, and it is just a very standard way of eliciting information from a patient. We include ICE, ideas, concerns, and expectations, within the communication and history taking. And then we all move into breakout rooms. Now, the breakout rooms are really important. So we have about 30 people on any session, 30 pharmacists on any session, and that's facilitated by an RPS chair and 3 clinical facilitators, of which one is a GP and the other 2 are advanced non-medical health professionals. So we will split into 3 breakout rooms, and activity 1 is about initiating the consultation, and we will practice that using the mnemonics that I've been talking about. And then we'll practice history taking. We move on to red flags, and we discuss red flags to do with respiratory, cardiology, that's unstable chest pain, general cancer red flags, you know, rapid weight loss, and talk about what they are and their importance. And these obviously are ones that need to be escalated. And we'll also talk about clinical assessments and observations. We do this via a case study, and we use a very classical sort of case study with an elderly lady who's been referred to the pharmacy with constipation. Her husband's unable to give you any more history, but tells you that Anne is not normally confused, but is currently confused. And we work in our groups through this case study. So we then move on to further activities. One of the activities is using videos of clinical examinations. Those examinations are really about taking saturations, blood pressure, temperature, and respiratory rate. Very simple clinical examinations. And then we discuss about putting that knowledge into practice, how as community pharmacists, they can work with general practices, make contacts, come in and practice taking blood pressures with the practice nurses, and just make that connection with their local pharmacy. So that's the summary of the first session, and then they have some homework to do, and that's given to them to do a video of applying the history taking with either a family member or ideally a consulted patient. The take-up rate of that is variable, but usually we will get 1 or 2 who come back who are willing to share their videos, and that's absolutely ideal. So at session 2, again, 2.5 hours, we talk about the feedback on the learning. We go into case studies, 2 case studies again, and then we talk about clinical transfer and safety netting. So activity 7 is showing the videos of them practicing the clinical assessments with the family member or patients. And then activity 8 and 9 are discussing 2 further case studies. Very common case studies: a 8-year-old with a viral illness and rash, and a 50-year-old with a cough and sputum. And we use what we've learned about red flags and about history taking to work through that activity. So the pharmacists will talk about the SBAR communication tool. So when they escalate, how to transfer information, which is incredibly important, that it's communicated in a concise and clear way. We go back and revisit Anne, who was the case study with confusion, and we talk about how this is documented. Now, I heard earlier on the webinar that there are 2 systems that are mainly used in pharmacy. From what I've picked up, there are other systems that are used for documenting in pharmacies, but everyone is happy that it can be documented, and we discuss the importance of that. So that is what we run through on the on the 2 sessions, and back to you, Gary.
Brilliant. Thanks very much, Johnny, for talking us through the training programme. And I think one of the things that's come out this evening is that this is about re-educating patients and altering expectations. But it's also really important to make sure we have appropriate training in place for the pharmacists and for the wider GP team, because it sounds as if a lot of the success is based on good care navigation and receptionists and the like. What I'm going to do now is we've got about 15 minutes left, and we'll jump onto the Q&A area. There's been a number of questions that have been asked, over 70 questions asked, and 51 of them have been answered already. So thank you so much for the team that have been working away in the background to make sure that we're getting the answers out to people. Because this is being recorded, and because the questions won't be available for people to read when they're having this section, I'm actually going to read the questions out, and then if the most appropriate panelist would just like to speak up and answer that question without letting me hang on silence for too long, that would be really appreciated. I think we've heard a lot about the theory, we've heard a lot about the practice, we've heard a lot about the training. A lot of the questions here are around the funding mechanisms here. One I saw flashed up earlier was talking about, could practices afford to pay their receptionists more to do the care navigation? But it does sound as if the amount of capacity that could potentially be generated would mean savings elsewhere. But I just wonder if somebody on the panel could explain to us what the funding mechanism is for this, please. How does the funding work, particularly, I guess, of interest to the community pharmacists?
Sorry, just struggling to unmute myself. Sorry about that. So the way that the pharmacists are funded, they get a fee for a referral for what's called a completed consultation. So if they receive a referral and they have a consultation with the patient, or if they have a discussion which results in a safeguarding conversation, even if the person says, actually, no, I don't need a consultation now, that still counts in the context of, that's important and really important. Where they won't attract a fee is if the person, they can't contact them and they're not contacted. So it's very clearly set out in the service specification, and if you like, the account of people who do not attend. But that's the fee that the pharmacist gets here.
Excellent, thank you. And that infers that there's no extra cost to the practice for this, because this is something that's contracted by...
No, not at all. Not at all. And in fact, this is seen as something that's all about enhancing access to much wider primary care. So as practices are thinking about how can we provide better access for our patients, community pharmacy is part of that team. How can we help improve better access for our patients? And if you like, the support that is going into practice at the moment, from that context, that's the support they have. And what pharmacy is doing is actually trying to work with practices for this to come together.
Brilliant, thank you. We've got another question that I think Anne Neville's going to pick up. And the question is, would the triage at the surgeries be done by the receptionists and or PCN practice pharmacists? And would the receptionists need further training? So Anne, if I can invite you in on that one, please.
We don't treat, the receptionists do not triage. So we have a template built within our EMIS system, which we've used from when we started care navigation. The care navigators simply follow that process, but they do not triage. So if a patient has one of a list of conditions that they can appropriately refer to the pharmacist, then they will do that. But we made it really clear to our receptionists that they're not triage. They're not trained to be triage.
No, but that care navigation's got to be an investment in time that you've got to be so pleased that you've made, because although you're using more reception time, you're saving doctor time, and that's got to be great for any practice.
I don't know whether Dr. Oom is still on, but he might be able to just explain that process of the template, because obviously he was really heavily involved in that. Thanks, Mo.
Yeah, I think from a governance point, a clinical governance point of view, and as a practice point of view, you know, we don't expect our receptionists to be doing any clinical triage. However, they can helpfully ask certain questions and not necessarily triage, but offer the option of the referral to community pharmacy without necessarily having to do clinical triage. So there is often a script around certain symptoms that would be really important not to miss, requiring a GP consultation. However, they won't be doing any clinical triage in its conventional sense.
Yeah, thanks, Mo. And I think certainly the experience we've had in our practice is that once the receptionists to start getting rebadged as care navigators, then the patients find that very acceptable and find it a really, really helpful service, because it directs them to an appropriate place early on in their journey. Richard, I wonder if I could bring you in on this next one, please. You say you're setting high aspirational goals for your team, and we've got a question here that says, if this really takes off, do community pharmacists have the capacity to take all of the referrals? I fear there is a danger of demand swamping the system. What's your view on that?
Yeah, and it's something when we looked, and we've been doing quite a lot of our work with our pharmacies around, I suppose, their own efficiencies and the things that they need to be doing versus the things that they don't necessarily need to be doing. And we've all done that across primary care because we've had to. Because it's important that we work with our pharmacists to free up time, especially in the morning, which is when we see most of the referrals coming through. And to be fair, that's when you see them coming through in general practice. We've now got pharmacists that are more than happy to manage between 5 and 10 referrals a day. As with anything, when you first go live with this, if a surgery sort of sends one today and one maybe next week, it's really hard for a pharmacy team to kind of get their head around that. And that's probably more difficult than receiving 5 every single day. Because once you start to receive it every single day, you get into the routine of doing it. And that's why it's really important that you, as part of the go live, you ramp up in a careful way. We did have one surgery that landed about 20 patients in a pharmacy on day one, and that sunk them overnight because it was just so different. So it's really, really important when you implement this service that you work closely with your pharmacy to scale up over probably the first week or two. And then as you reach that natural plateau for your surgery, you'll find that you'll naturally maintain that level. And then you'll go back and you'll iterate the process by having those conversations. So they absolutely can go. We just need to change some of our working practices, and then it gets into a routine. And if you find pharmacists that are struggling, then it's really important probably to contact the local pharmacy committee that's in your area to ask them if they can lend a bit of a hand and help with that pharmacy.
Brilliant, thank you. Moving on to a slightly different area, there's a question saying, is there any way to make over-the-counter medications cheaper than a prescription, or allowing more medications to be over-the-counter and not prescription-only medicines? The questioner said this would massively help. I don't know who would like to pick that one up.
You want me to do that one as well?
Yeah, please.
Most OTC medicines are cheaper than a prescription, in all seriousness. I showed you some of the data that showed that sort of 35% of patients don't need to buy anything. So that's completely free. Lots of the self-care products are, under the cost of a prescription, and are certainly sort of £5 price point or lower than that. And certainly, that's part of the conversation that needs to happen with that patient. So, like I said, even in some of our most deprived areas, it's not a problem so long as the teams approach it in the right way. It's all about the conversation you have with the patient and the way you approach it.
Yeah, as is true for any change management program, isn't it? It's really important to get people on board. It's really important to take it at an appropriate speed, and it's really important to be able to be flexible and alter the path as and when's needed from the learning that you get. Certainly as a GP, I think it's true to say that any new service or new pathway that is easy to use is good for patients and good for the practice, tends to tends to stick quite quickly, and the training element is really important. A question for you, Johnny. In terms of the training, do you find that most people, having gone through that training program, they're obviously then competent to the point that they can start doing it, but one would expect it takes a little bit more time to build confidence to a level where people are happy with this, because that's got to be true of any sort of learning, isn't it? And just wondered if you had any reflections on that.
So certainly I've got reflections. I don't know the actual answer because, of course, we haven't done any follow-up of pharmacists that have joined the scheme. I think probably Richard is ideal at answering that. But most of the community pharmacists that we've taken through the programme are incredibly skilled healthcare professionals who are just waiting to use those skills and are happy to use those skills. So Gary, I think once the training's happened, with a bit of practice, they're up and running with it.
Okay, thank you. Mo, there's another question for you here. It's saying, for the extensions to the service that Mo mentions, that is PGDs and prescribing, which organisation pays the community pharmacist for this? Is that a CCG commission service? Is it through the PCNs or NHSE? I don't know if you know that, or maybe Anne might.
I think Anne might probably know that better than I would. It's part of the extension of in our areas, the additional PGDs part. The consultation is extension of the consultation scheme. Well, the exact approach.
Yeah, I mean, so it's probably helpful to just clarify. So what's being funded through NHS England Improvement is the consultation with the pharmacist. And that is core to every part of the 10,000 pharmacies who provide it. Anything that's sort of added on as an enhanced service, which is certainly what Mo's talking about in his area, is a commission service that's been commissioned locally through his CCG. And that's a CCG decision to add that on, if you like, to the service.
Okay, thank you. We've got a question from Jenny here that says, we haven't heard much about how much time it takes to do the implementation. How did those practice managers and GPs find the time to coordinate with pharmacists and do the training? Did they put other things to one side? So I don't know whether that's Richard's bag or Mo's bag, or probably a comment from both of you.
I can certainly pitch in with what we've done within Avon. So Judith goes along to the surgeries and has delivered a combination of either face-to-face training or Zoom training. Certainly face-to-face she's found easier, even during COVID. We do a number of sessions with the surgery team, normally 2 sessions, possibly 3, depending upon the surgery size, to make sure that you've always got people available to manage patients coming through the door. And they tend to take about an hour for each session to get people up to speed. And then beyond that, there's some support that we're there to answer any questions or give them any help and support post that sort of go live to get them up and running with those first few. What we're in the process now of is managing the process of hand-holding that relationship back to the local community pharmacies, because as an LPC, we are struggling now to manage the relationship with those 80. We need our community pharmacists to now be picking up those conversations to do the ongoing, continual management of the service.
Brilliant, thank you. Mo?
Yeah, just to add on to that, I think it's about thinking for the future and investing the time early on. So everybody's under pressure across all organisations, and I recognise that colleagues may find difficulty finding 1 or 2 hours to put into some of that support with community pharmacy colleagues, but I think it's well spent. For when we just talk about the numbers there, 135 clinics saved over 18 months by spending a few hours, 2 or 3 hours, 18 months ago. So I think it's about thinking about as an investment, making sure practices have some time around protection to support some training. As I said, it's time well spent for thinking about the outcomes you get later on.
Brilliant. Okay, we've got a question here from Shoaib. I'll start with an apology because they're asking, can I have a request to the response? They've posted twice The reason we haven't got there is just it's my total inability to look at 3 screens and speak at the same time. But I found your question now, so apologies that it didn't get put forward earlier. But it's saying if a locum pharmacist is working in an area and advice and referral, for example, to a pharmacy that is able to prescribe under PGDs, is that the most appropriate step? And how would such a locum pharmacist know where or how she would check where to relay the patient onto? That sounds like it's something that whoever is in the substantive post should make eminently clear to the locum. But perhaps, Richard, you'd like to come in with an answer there.
I'd agree with you. Okay, so firstly, the PGDs are not part of CPCS. So from the concept of going live, as Anne said, the service itself is that referral across. Now, if there are PGDs available within that pharmacy, then a locum should, the pharmacy team or the person who's booking that locum should make them aware of the services that are available, and the locum should equally make sure that they furnish themselves with enough skills to be able to deliver things. But it's the challenge across the country, isn't it, as to how we get that consistency of delivery. In each individual situation, I think those pharmacies need to be, that's part of that implementation program of working with your LPC to work out what is and what is not available locally. And we do a huge amount of work across Avon to support our local population to make sure they realise that there are PGDs available.
Okay, brilliant, thank you. A couple of questions that are on a similar sort of line here. So the first one is, if a pharmacist gets a fee for a referral, will they then tell any walk-ins to go to the GP for a referral? I think any new system, there's a potential for gaming, but I think professionals are probably above that 99.9% of the time. But Richard, have you got any experience of those issues?
No. Nothing. We're constantly trying to get patients to actually come from the surgery and get the surgeons to send them to us to free up the time in the surgery. Definitely, I would be very disappointed if we found a situation of a pharmacist doing that for a patient who walked through the door and should just be able to access advice. Most of what we spend our time doing is working with our surgeries to get the formal referrals to come across to the pharmacy so we can deliver the service with the right level of clinical governance wrapped around it.
Excellent. Okay, I'm just going to end with a bit of a plug and then with one final question. So looking at the chat, Hussein Kaki's posted in there saying that he's a GP trying to set up a better software solution and some solutions to support scaling up in his area. So he's made an offer to Devon LPC and left his nhs.net address there. So anybody from Devon, if you have a quick scroll through the chat before we finish, you may have an offer of help there. And then a question that says, will we be moving things forward to think about patients self-referring into this service? I don't know, Anne, whether that's one you can answer. Is that something NHSE are considering, taking the GP surgery out of the equation completely?
So we're very keen that this is part of joining up pharmacy with general practice. And we see the important aspect of this is about navigating patients to the right place first time. And one of the areas we're looking at, and particularly, if you like, our next development of this is through looking at online consultation tools. So at the moment, I guess if you think about it in the context, what would be a direct access is, yes, we are exploring that. But at the moment, I think in terms of somebody walking into a pharmacy, our general perception of that, it's a different relationship. People walk into pharmacies all the time. And I think there's a general view that that's a sort of self-care conversation. What we're talking about is in the relationship with general practice, this is your other healthcare professional down the road from you to the practice, and it's a different type of consultation. So that's what we're sort of exploring, but we are looking at the online consultation route in as part of our project.
Okay, thank you. Got a question from Julie Jones, because she's also commented that her question hasn't been answered. I don't know if this is the one you wanted answered particularly, but it's saying, will we see any audits that show us utilizations of the service? Is there going to be anything published nationally on how this is going? I imagine evaluation is an important part of the rollout.
It is an important part and definitely of that. And certainly in the early stages of implementation, this is where it's really important with the LPCs and the local teams working together in actually sharing data in terms of activity and feeding that back. I certainly hear from what you've said previously, Richard, that's a really important part, is how many patients, when the practice does refer, how many actually do take up the offer of that consultation and physically have that consultation, or which ones are DNAing. So that's really important. But longer term, we'd be very interested in looking at audits for this service, definitely.
Brilliant. Okay, thank you. And the final question, I mean, I'm totally sold on this. I'm sure there's others out there that have listened to the contributions and the presentations tonight and really want to crack on with this. Where do they go to sign up? Where do they go for more information? If they sort of need to get their practice on board, how do we sign up for this?
So on the links that we had on the slides that I had, there's an NHS Futures website address on there to find all the materials, and also you'll find your regional implementation leads for each of the NHS England improvement leads. We're also very aware that on a more local basis, the LPCs are very keen to engage on this. So I'm sure they could also help sort of facilitate conversations, and certainly with the LMCs, very keen that there is that sort of interaction on how to take this forward. But hopefully, as you said, the slides are being shared, I think, from this presentation, and the links are on there. So on the Futures website, you will find all the links through there and the email addresses.
Yeah, and
I think it's just been posted. Thank you.
Yeah, and I'll say someone's just stepped in and posted that on the chat. So I'm afraid we're out of time. We're more than out of time. I've run over, which is appalling chairing, but I think these questions were important to get in. So first of all, I'd like to thank everybody that we haven't seen on screen tonight, those people that have helped with getting the webinar up and running from both NHSE and from the RCGP. So thank you very much to our backroom team for allowing this to happen. A huge thank you to everybody on the panel that has presented or answered questions, and most importantly to the 200 odd people that have stayed with us throughout the hour and a half for what is a really exciting way of collaborating between different parts of primary care. And we know the future's collaboration, and this is a great example of what an impressive difference it can make for our patients. So thank you everybody for your time this evening, and look forward to hearing the success stories as other people implement around the country. Thanks and goodbye.